keep your phones on silent for the duration of the program, but we do encourage you to have the conversation online on social media using the hashtag #TheHillHealth. And you can also follow us on Facebook, Twitter, and Instagram at The Hill Events. Now, it's my pleasure to welcome our first guest of today's summit this morning, Dr. Jack Resnick, the president of the American Medical Association, and he will be joined in conversation with the Hill's editor-in-chief, Bob Cusack. Welcome, Dr. Resnick and Bob.
Thank you. Good morning.
Thank you. Thank you. Oh, we're switching? Okay. I'm sorry.
We can do that.
Hey, we haven't been in person in a while, okay? Jack, thanks for joining us today. And first of all, it's great to see everybody. It's been 2+ years. We've been doing these virtually, and it's great to be back in person. This is an event, Future of Healthcare, so let me tee it up for you. What is the future of healthcare, both short and long term for physicians, but also patients?
That's a good question and a really that's a good question and a pretty broad question, I guess. Future of healthcare, I could talk about almost anything. I think, as I took my oath as president of the AMA about 3 weeks ago, so I'm relatively new in this role, and I feel like I'm taking it on at a really interesting time for my colleagues in medicine. I look out and think about the 2.5 years that they have lived through and this point where we are in the pandemic, and there's a lot going on. First of all, I've never been prouder to be a physician as I think about what physicians have really endured these last 2.5 years. Fortunately, we're no longer at a point where people are not having enough PPE and wearing trash bags to protect themselves at work or sleeping in garages to protect their families. But physicians have endured a lot of disinformation, a lot of anti-science aggression, and have really done a lot, I think, to educate the country. So I just have great pride in that. I do think we've reached a point where it's time for the nation to actually renew its commitment back to physicians. So at the AMA, we are thinking a lot about and talking about a recovery plan to kind of help healthcare going forward. So we can talk about some.
Talk a little bit about that. What's in the recovery plan?
So a piece of this is really just dealing with burnout. As I look at my colleagues around the country, there is a tremendous amount of burnout coming out of these 2.5 years. And some of that we don't even have, with the stigma around mental health and physicians not being able to, sometimes if they're depressed or at risk of suicide, do things about that. So that's one of our pillars. There's another that's really focused on the actual obstacles and burdens that get in the way of us providing the great healthcare to patients that we went into medicine for. So whether that's things like the prior auth process just to get people the medications they deserve, or dysfunctional technology around EHRs, that's electronic health records that still don't work well, thinking about the future of Medicare, thinking about raising up physicians as leaders of healthcare teams. And then the fifth pillar is really around technology. And so more in line with, I think, some of the things you'll be talking about today. Physicians were not on the ground floor of innovation a decade ago. So if you ask the average doctor, what do you think about your electronic health record? They're going to say, well, this was clearly not designed by physicians for physicians, right? So as we think, whether it's telehealth, whether it's augmented intelligence and some of the cool new tools that we have, we really want to make sure physicians are involved early with sort of our lens and our values to make things useful so they actually affect health of patients.
You're going to be testifying later today. I want to ask you about government involvement in healthcare. Obviously, we've seen a huge Supreme Court decision. What are you going to be saying later today?
It's a really dangerous time for doctors and patients. I think if you've watched the news the last few weeks, initially it sort of seemed like anecdotes of what was happening in some of these states with patients showing up in emergency departments with ectopic pregnancies or complicated miscarriages with an infection or something else, that literally physicians are finding themselves in a place where they are stuck between their ethical responsibility to take care of the patient who's in front of them and do the right thing to save a life or improve the health of that person. And they're at the same time facing a web in some of these states of conflicting and very confusing laws. Some of the laws that have gone into effect literally were on the books from the 1800s, far before we had sort of the modern healthcare world that we're in today, and others that have been added more recently. So literally, doctors are having to pick up the phone, call hospital attorneys, and get permission to do basic things in healthcare when lives are on the line and minutes matter. So doctors are incredibly frustrated right now. They're pretty frightened about these situations, and we're trying to be very clear to policymakers just how dangerous it is to be a physician and feel like sitting on your shoulder is a state attorney general or a state legislator or somebody else who's going to be second guessing that care. It's so wrong to have politicians and government inserting themselves into these decisions that really should be between patients and their physician.
What do you think is the answer?
Well, in the past, our remedy when a state made a bad decision like this was the courts. But with this Supreme Court decision, that remedy, I can't sugarcoat how hard and how dangerous this is. So part of it is just convincing states not to pass some of these laws. We'll win some of those battles and lose others. And there will be other opportunities to litigate. So you saw the administration last week put out guidance on a law called EMTALA. Many of you may be familiar with. This is a law that basically says when somebody shows up in your emergency department unstable or at risk of death, regardless of insurance or anything else, you have to take care of the person in front of you. So we were very appreciative that the administration actually put out guidance that supersedes any state law. But then you have Texas actually suing to disagree. So the physicians are still in this very uncomfortable position where they don't know if their decisions to take care of the person in front of them are actually going to be criminalized, if they're going to face, in some cases, felony jail time, again, for taking care of the person in front of them who may have a dangerous ectopic pregnancy, who may have a complicated miscarriage. There are all kinds of scenarios. The other thing we're seeing is this is spilling over into other drugs. So I happen to be a dermatologist in my day job. There's a drug called Methotrexate we use for a lot of things in healthcare, cancers, autoimmune diseases. Well, doctors are now finding that pharmacists in some of these states are refusing to fill prescriptions for Methotrexate because it happens to also be used to treat ectopic pregnancies, and they're scared of the state coming after them. So we have an enormous amount of work to do to try to mitigate some of these challenges so that patients' health can actually be protected. But it's a really challenging moment.
What do you think, obviously, the role of telehealth has exploded post-pandemic. A lot of people, including myself, never had a telehealth appointment, but I think most people have had it. Where do you see that going, and how valuable is that?
Well, there are very few silver linings to COVID-19, but I think the explosion in the use of telehealth over these last 2.5 years has been an amazing positive. In terms of the flexibility that it's granted, it's actually helped with some of the health inequities that we face in terms of making it easier to get access, to get in and see healthcare, see physicians. In the first months of the pandemic, when offices had to completely close down, and we were able to get Medicare and commercial insurers to actually turn on coverage for telehealth, which had been the big block for several years, we saw this enormous increase in its use, and it has settled back down to somewhere in between, which I think as we learned and figured out in each specialty, what are the things that telehealth is really good for? When do you actually need to see somebody in person? So that's been a big part of the evolving evidence, is actually figuring those things out. Interestingly, people may not know this, but the future of telehealth is a little bit at risk. So under the Medicare current law, when the public health emergency ends, a few months later, Medicare will revert back to the old rules, which essentially say if you're a Medicare beneficiary, unless you live in one of 2 states or an extraordinarily rural area, you can't get telehealth. And even if you can't use your own device. You have to go to a special presenting center. It's not consistent with current technology and really what's best for patients. So we've been working with Congress to encourage, and there are a number of bills actually under consideration right now to extend that. The commercial plans in the states are going to have to do the same thing and think about extending this access to this great new technology.
One of the big narratives of healthcare, and I used to cover it many years ago, is making healthcare fair and health equity. Where do you see that going? We've seen that with COVID too, that if you're wealthy, it's easier to get treatment.
Yeah, health inequities are not new in this country. I think COVID, in a way, pulled back the covers and made it very apparent to a lot of people who may not have known before the extent to which Black, Latino, Indigenous, LGBTQ, rural patients actually face as many health inequities as they do. It is a huge priority for the American Medical Association. We've been around for 175 years, so a piece of this to build trust in marginalized communities has been us reckoning with our own history. Because during those 175 years, we have not always been on the right side of health equity. So that's a big first step that we have been taking. But simultaneously, it has felt very important to me and to the AMA broadly, as we have invested in a health equity unit within AMA, that this not be a siloed thing. I knew it would be successful ultimately if we reach a point where your zip code or your race is not a major determinant of your health outcomes. But in the medium term, I know our work is on the right track when I see that it is affecting every unit in the organization. So whether it's our medical education team that's thinking about the pipeline of future physicians that needs to look more like the populations we serve and be more diverse, or medical school curricula that need to prepare future physicians to actually go out and reduce health inequities, whether it's our chronic disease group that is actually meeting different communities where they are and making sure that we're in the right places to affect, for example, a program called Release the Pressure that focuses on Black women with hypertension. Whether it's our litigation group that has gone after FDA in the past for not regulating menthol in cigarettes, which has had devastating consequences for generations of young Black men who have been targeted by tobacco companies. And again, whether it's our innovation team, so people don't think about this much in the innovation space, but we have seen really fantastic, exciting things happening in innovation. But if you don't start with an equity lens at the beginning, if the right diverse people are not in the rooms with entrepreneurs and funders and physicians who are thinking about health equity, you end up with tools that maybe not on purpose, but tools that actually cement inequities, like AI tools that learn from existing inequities and actually build them into the decision-making process. Right. As they do their machine learning. You saw probably the example of a large major national insurance company who created a tool with good intent to try to identify patients with chronic disease who are likely to get worse in the next year and need hospitalization, and so they could target additional resources to help those patients. But the tool learned from our existing expenditures, which are based on who has access to healthcare. So if you put the exact same patient into that tool with the same chronic diseases and the same medical record, but just change their race, it would steer all of the resources to the white patient and not the Black patient. So as we think about innovation, we are thinking a lot about and have fantastic people that we brought into our team with real expertise in this area and external advisory groups so that we can make sure that future innovations actually help us to solve equity problems.
Well, we've run out of time. I know you have to testify. Please thank Dr. Jack Resnick for joining us this morning.
Thanks so much.
Hey. Thanks so much. Thanks.
Our next guest is former FDA Commissioner Dr. Stephen Hahn, CEO of Harbinger Health and CEO partner of Flagship Pioneering.
Thanks for joining us, Steve.
Thanks, Bob.
You know, we talked a little last week of you were on the front lines of a historic event, I'm sure a frustrating, exhausting event. You've had time to now reflect now outside of government. What are your personal and professional kind of observations about COVID?
Yeah, for me, two major observations that have stuck with me. One was the power and the importance of the private sector in cooperation with academia and government. I mean, you think about the identification of the SARS-CoV-2 virus and the genome, and then basically the authorization of 2 vaccines 10 months later. It's a remarkable event, and if we hadn't had the cooperation of government, science, academia, industry, we wouldn't be where we are, I think, today even. So it really struck me that the vibrant private sector, certainly in cooperation and collaboration with government, was a really important part of this. The second thing was, during the time of the vaccine development, we spent a lot of time reaching out to folks to really discuss how vaccines are developed. So a lot of interest in the science and the development. But what really struck me was that those who were the most marginalized in society, those who had the least access to care, were the least trustful of the process of science, of medicine, et cetera. And we really need to do something about making sure that there's...
Why do you think that was and is?
Well, you know, there's a societal issue here, certainly in terms of divisions within the country, but
Sure.
I think we probably in medicine and science haven't done a very good job of communicating about the importance of science and medicine and how this really can help the human condition. And so I think this issue of equity and making sure that people have access and the innovations that are coming from science and medicine and biotech, I think we have a really important moral imperative to make sure that they're available to everybody. And that's not just an economic, let's build trust and have communication about it.
What did you learn about the healthcare system? As you mentioned, the vaccine development was historic. It was a frenzy, but there was a lot of public-private partnerships. But what flaws did it expose that policymakers need to address?
So, you know, one of the reasons I went to Flagship Pioneering is because we have a preemptive medicine and health security initiative. So how do we be proactive about creating a health shield to predict what the next pandemic might be, or even if in the context of SARS-CoV-2, what's the next variant we have to be concerned about,
right.
And how do we actually work in a similarly very fast fashion to actually get a vaccine or other treatments for that variant. So really anticipating, and the data are available, and we live in an era where if we can analyze the data and use it and turn it into therapeutics, vaccines, et cetera, it could really work. But the thing that struck me, and now the papers are coming out about this in the literature, the one underlying factor that seems to be the most important in terms of COVID and mortality is chronic disease, obesity being a big one. And so if you think about the challenges facing healthcare in this country and the world, frankly, it's chronic disease. We're heading toward a cliff in terms of the number of people with chronic diseases. So how do we actually identify chronic diseases before they develop and then intervene? Similar to what we do now with cardiovascular disease, identification of hypertension early that's asymptomatic, and cholesterol. So let's do that for cancer. Let's do that for Parkinson's. Let's do that for Alzheimer's and obesity.
Can it be done?
Sure. If we can put together a vaccine and have it authorized in 10 months, we can figure out what the factors are associated with chronic disease and intervene early. It's certainly within our power. I think the data are available for us to analyze and to start thinking about what are those biomarkers, surrogate markers, et cetera, that allow us to predict who's going to develop certain diseases and then develop interventions.
Have you seen that the trust between stakeholders, like government, the government policymakers, as well as outside companies, has improved post-COVID? Because there's always the friction there sometimes.
Yeah, there's a necessary tension, I think, having sat in the regulator seat and now being on the other side of the table. Right. I think that tension can be good. I think what we're seeing in terms of the PDUFA 7, the user fee negotiations with pharma now, there's also a real call for transparency and dialogue between regulators, public health officials, and industry. I think that's a really good trend. I think we need to see more of it. So appropriate oversight, but real transparency about what's required to develop innovations in a safe and effective manner.
When you were dealing with this bizarre virus, was there anything that you thought, well, in the future we need to have more resources devoted to that, and that's what we need to prevent the next one?
So a couple things. One is a basic infrastructure around information gathering and collection, and information dissemination. So I'm thinking back to the task force times, and we literally set up a bank of telephones for folks to call hospitals around the country. I mean, this is 2020. Mm-hmm. And even at the agency, we had folks on the phone 24/7 calling, suppliers of API, of pharmaceutical precursors in China, in India, et cetera, to make sure that they were available for essential medications. I think we need to really revise and revamp the infrastructure around information gathering and information dissemination. So that would be one. And of course, like in any medical emergency, information dissemination is really important. The other thing is what I already mentioned, which is I think we really need to address the chronic healthcare issues. I'm a cancer doctor, and so I'm really focused on that now. And I truly believe that we're going to be able to identify cancer before it's visible and really intervene and turn it into a disease not to be feared, but to identify and treat early and cure.
And how long do you think that is off, the cure?
Yeah, well, it took us 50 years to identify from the Framingham study hypertension, diabetes, cholesterol for cardiovascular disease, and then effective therapies. That was a 50-year journey. It can't take us that long. So we need to get industry, regulators, the medical community together to figure out how to do that. So my crystal ball was never very good being a lung cancer doctor, but I'll tell you, I think we should do this in the next 10 to 20 years.
Where are we with COVID? Is it going to be with us for 2 to 5 to 10 years?
Well, one of your next speakers is probably much better able to predict that, but from what we've seen in terms of the predictions so far and where we are right now, I think this is with us for some time. 2 to 5 years is reasonable. Maybe it's like the flu. It'll be here for ever, and we just have to accept the fact that variants will occur, and we need to address those variants. So it's not going away. The variants occur. We know at the 8.5 right now that we've seen a significant spike around the world. Let's learn to live with this and do it safely. And just one point, again, being a cancer doctor, what we really have to do is to figure out how to protect the most vulnerable among us. Those because of socioeconomic conditions, but also because of chronic diseases. That's a nut we need to crack.
What's your expert opinion on long COVID? It seems like that has triggered a lot more concern, a lot more cases that we've seen. That people who've gotten it have gotten this long COVID, which is very concerning.
Yeah, it is very concerning, and it's real. I believe it to be real, and we sort of have to deal with it as a real illness. If you think about other viral illnesses, EBV, sometimes flu, but EBV and other Epstein-Barr virus and other viruses, a prolonged syndrome afterward does occur. So I think it's part of that same pattern. It seems to have effect brain, heart, musculoskeletal system, and we need good research and actually good information and data about the natural history of it to help us intervene. So what are the sort of biomarkers and other risk factors associated with it, and then let's develop the therapeutics to treat it.
As far as investing, where do you think the government should invest? Because a lot of people were, you look at the investment of trying to prevent something like Ebola, and that was in the headlines for a while and is kind of back again. But where do you think that the government needs to invest, whether it's in agencies or in public-private partnerships, to encourage innovation, to make sure the patients, all of them, get it?
Yeah, well, first of all, in terms of making sure everybody gets it, really important issue. And I think it would be very reasonable for the government to create programs around increasing access. So how do we incent the private sector to make sure that not only are innovations available to those most in need and those who don't have access, but how do we ensure that they're part of the process, because we spoke about trust, of actually creating those innovations, so clinical trial diversity, et cetera. So really incent the private sector to do that, and I think if those incentives are in place, it will happen. The other thing is I mentioned the informatics, how do we collect data and disseminate it? And then I feel strongly about the fact that one of the key factors for identification of chronic disease before it comes is a shift in our mindset around the regulatory framework. So how do we actually allow those therapies and identification of pre-disease to flourish? And that's going to require a shift in how we do things. And we saw with the recent aducanumab decision with FDA and the use of surrogate endpoints of biomarkers that that's controversial. So let's get together and figure out what is the appropriate science that allows us to do that identification and then intervene early for these diseases.
As you mentioned, there's been a polarization of the country, and healthcare in particular is certainly partisan. But when you look at the track of Medicare, policymakers are going to have to come together and get some type of bipartisan compromise, like the Balanced Budget Act of 1997. Are you concerned about that, the sustainability of Medicare and also the workforce with an aging population?
Well, your most recent guest, the president of the AMA, really spoke to some of the issues that colleagues and friends in the front line are seeing, and I'm very worried about that. The profession is just too important for us. I think all of us need to say that it's not acceptable that healthcare has become a partisan issue. That this is something that everybody needs and deserves, that access is really important, and that we're all in this together. If we didn't learn that we were all in this together from COVID,
right,
then we're never going to learn this lesson. So I think it's really important that we stop that and say, this isn't partisan. Let's think of ways that we can bridge the gaps that we have to actually develop solutions. So the FDA user reauthorization bill that was just approved in the House of Representatives, great example of a bipartisan effort to try to bring together for public health efforts. We can do it. We just have to start having some conversations.
And to be fair, there have been, as you mentioned, bipartisan healthcare bills. The Cures Act a few years ago was a big bipartisan effort,
yep.
And was hailed as such. So
Operation Warp Speed, Cures,
yes,
et cetera. I mean, it was a great example of what we can do when we get together around a common goal.
It has to be a little more common, I think. Dr. Stephen Hahn, thank you for joining us.
Thank you very much.
Please welcome Dr. Lishan Aklog, Chairman and CEO of PavMed and Lucid Diagnostics, and Kathleen Koch, author and journalist for A Sponsor Perspective, presented by AdvaMed.
Dr. Aklog, thanks so much for joining us this morning. Your story is simply fascinating. You fled political violence in Ethiopia as a young teenager. You ended up a Harvard-educated and trained heart surgeon, and now you're a medtech entrepreneur and CEO. Now, that journey must give you so many insights into the topics we're discussing today. Could you share some of those?
Sure. I'm happy to talk about my journey, even though I'm sort of a humble guy, but it does provide, I think, some significant insights into many of the topics for today, in that I've had a multi-hued, some might say winding road to where I am today, and it's provided me with perspectives from multiple angles as to where we are with healthcare. As you mentioned, I spent the first half of my career as a heart surgeon, practicing in Boston at Brigham Women's Hospital and elsewhere, but I always had this passion or drive for innovation, for figuring out ways to address unmet needs and to improve what we do. It was a bit of a tick of mine, I guess you might say, and that evolved into coming up with certain inventions and developing a path towards becoming an entrepreneur, where I joined up with a couple of partners, and we created some early startup companies while we were still practicing heart surgery, which I think back was a bit crazy. But we had some success, and we developed a variety of technologies. We developed a device to suck out blood clots that actually put heart surgeons out of business, which is wow, sort of
fascinating.
There's a history of that, actually, and that device was called AngioVac, and it was really after that that I saw, there's a lot of satisfaction, obviously, in heart surgery is very dramatic and saving lives and so forth, but I also saw the opportunity to use technology to develop technologies separate from the actual practice of medicine, and transitioned into full-time entrepreneurship and starting my own companies.
Talk to us about how your work and that of your colleagues is really helping mold and shape the future healthcare ecosystem. What are some of the standouts?
Yeah, what we've taken a path. We founded a company 7 years ago called PavMed, and it's a bit of a contrarian path. Instead of focusing on individual areas like heart or orthopedics or so forth, we decided to take a very agnostic approach to look at any innovation and be in the position to develop medical technologies. And medical technology is something, we're a little bit of the ugly duckling in industry. People hear about blockbuster drugs and vaccines and so forth, and sometimes I feel it's important to help define that. So, medical devices, medical technologies are not simply devices, tools that doctors use to intervene and, in the heart and elsewhere, but it includes really three major areas: medical devices, diagnostics, which we got a lot of attention for obviously during the pandemic, and digital health, which is an upcoming area. So our small company, PadMed, has actually committed to being involved in both. So we have products in more traditional medical devices, better ways to do carpal tunnel syndrome. We have a diagnostic company that has called Lucid Diagnostics that has an exciting early detection process for detecting precancer in patients who have heartburn, and we also have a digital health platform for cancer patients. So, and one of the interesting things that I've been fortunate is to get another perspective, and that I was asked to join the board of Epidemic. So now I actually have, I can see from the policy side as well how, what we do as a country and as a community impacts access to innovation in medical technologies.
Let's talk about that. Access is one of the issues here that we're discussing, health equity. And I know it's got to be frustrating because we all know that not everyone has access to all these innovative medical technologies that you and your colleagues are creating. So what is your concern about the impact that disparity in access has on patients' health and well-being?
Yeah, we talk about disparities in health equity. I know that's a theme of this summit, somewhat often in somewhat theoretical terms. I'm actually on the board of Human Rights Watch, so the concept of access to health as a right, whether you believe that or not, or just from a pragmatic point of view, from a policy point of view, is sort of central to my heart. So I think maybe the best way to explain it from a technology point of view is to just give a concrete example. So one of my colleagues on the Epidemic board, I'll credit him with this. About 10, 15 years ago, there was new technology that allowed you to treat heart valve disease without having to open the chest and do open heart surgery. These are called transcatheter aortic valves. And now we're 15 years into this. It was an absolutely groundbreaking innovative technology. And what the story he likes to tell is that at the beginning, and even to this day, we know that access to this very mature technology that's been around for over a decade is inequitable. And the example he gives, he lives in LA. He says, if you were in Cedars-Sinai the day these technologies came out, Cedars-Sinai could basically make it a loss leader and present it as cutting edge technology that they could offer to their sort of upper socioeconomic patients. But you go a couple of miles to MLK Hospital in LA, and to this day, patients, even 15 years later, do not have the same access to that.
Was there anything that the policymakers, the lawmakers, people in this room can do to help change that?
It really comes down to the process being predictable. Now that I'm on the other side and I'm bringing technologies to market and so forth, we need predictability, and one of the areas is in reimbursement. So there is actual work that came out of the Cures, the spirit of the Cures Act, that is now called TSET, and that basically tries to provide a predictable reimbursement path, particularly for innovative technology. So it doesn't become something that only wealthy areas can provide sort of as a loss leader until the market figures it out. So there are definitely policy initiatives that we can work on to improve that in medical technology.
Your work has traveled the worlds of both the clinical medicine and then medical technology innovation. And so I think that puts you in a really unique position. As we wrap up here, drawing on your many worlds that you've had your feet in, what excites you most about the future of healthcare and the role that medical technology will play in it?
We could spend an hour. Do you have an hour? I mean, there's a lot of exciting things that are going on, and I would be remiss if I sort of didn't emphasize that. I think one area that I find extremely exciting and something we're involved in is the intersection between the digital world and technology. Now, we always think of medical devices as being sort of high-tech instruments, but the digitalization of existing tools, but also the application of digital health much more broadly across healthcare is something that's extremely exciting. And just a quick example of that, there's an initiative right now in healthcare delivery that's just getting underground. My alma mater, Brigham and Women's, announced it this week that they're going to try to develop 200 hospital at-home beds. So patients don't actually get admitted in the hospital. They're at home getting treated for things that would previously require hospital care, not sort of just sending them home afterwards, but truly getting their care at home. That requires careful monitoring. We have the ability now with implantable and wearable devices to monitor patients at home at the same level of intensity they could in an ICU. where you're getting continuous measurements of various physiologic parameters that can influence that. To me, that's a really exciting, almost paradigm-shifting way to where technology can impact how we improve healthcare delivery.
Any of your projects that you have in the hopper that you can give us, a little preview on, some insights?
Yeah, I mean, we have a subsidiary we launched last year called Veris Health, which is using digital health to improve cancer care. So patients most patients who require chemotherapy or immunotherapy require an implant of a port for that to be delivered. And we're taking that port and converting a dumb port into a smart port that can actually provide continuous monitoring of parameters that allow the physicians at home through the patient's cell phone and through a cloud-based platform to effectively monitor patients while at home and pick up complications such as sepsis or other things at a much earlier stage to prevent complications. So that's sort of an example of what I was talking about in terms of the impact of digital monitoring and digital technologies in improving care, something we're very actively working on.
And then there's your esophageal cancer.
Yeah, that's
preventing device, detecting and preventing.
Super excited about that. I think Dr. Hahn mentioned the concept of prevention. And one of the fastest growing cancers right now is esophageal cancer. It doesn't get a lot of attention. It's the second most lethal cancer. About 80% of people die. And it arises from heartburn, something that we all know about. It's very common. 50 million people have weekly heartburn. They don't know that they're a setup for potentially esophageal cancer. And so there are now biomarkers, again, like he mentioned, that we have a biomarker called Usaid, which can detect esophageal precancer. So not detecting cancer, but preventing cancer by detecting the precancer. And once you detect the precancer, you can monitor it, you can treat it before it develops into cancer. And so non-invasive
you can save
techniques
lives.
Absolutely is an opportunity to save lives. And that's the goal of the cancer moonshot of this administration. And we think we can play an important role in that.
Dr. Lishan Aklog, thank you so much. CEO and co-founder of PAVmed and Lucid Diagnostics.
Great. Thank you, Kip.
Thank you.
Please welcome Dr. Lisa Fitzpatrick, founder and CEO of Grapevine Health, and Gulshan Mehta, head of the Bayer Institute for Health Innovation at Children's National Hospital and Oracle Cerner. The Hill's healthcare policy reporter Peter Sullivan will lead this discussion on technology and care delivery.
All right, so let's dive right in. When I heard we were talking about technology and healthcare, I feel like there are two ends of the spectrum, which is there's a lot of exciting stuff going on in healthcare technology, but on the other side, I feel like a lot of people in this room probably experience, you go to the doctor's office and they want you to fax in a health record or something, and so I guess maybe I'd start with Gulshan. How do we kind of bridge that gap so that, in the daily average person's experience with the medical system, they are getting the benefits of the technology, and it's actually, filtering down not into some separate compartment, but it's, something that everyday people are experiencing?
Yeah, thank you again for having me here. I'll contextualize a little bit about my role, just so I can answer this question from a couple of different perspectives.
Yeah.
So I head the Bayer Institute for Health Innovation. It is a collaboration between Children's National Hospital, an eminent pediatric organization out here in the DC area, and then Oracle, which is, Cerner Corporation just got acquired by Oracle, a leader in terms of healthcare and innovation and such. Sitting at that crossroad of health and technology, myself and my team, we get a chance to get a unique perspective on some of the challenges that have existed over the course of the last decade and a half in terms of digitization of the health record, but now being able to go out and bring more utility to all the hard work that has actually taken place. The promise is significant as we start looking at the ability to go out and utilize health technology in a way where the organizations can have more equitable use of it for all those that depend upon it, whether it's the caregivers or the patients and the families. I think that is really upon us right now. So the access to technology and the ability for technology to go out and deliver on some of that promise has made a tremendous amount of advance over the period of time. Now it's really a question of being able to go out and have the means for everyone to be able to utilize it in a way where there can be actually meaningful outcomes as a result of it. So being able to go out and have the ability for patients and families to interact with their caregivers on an ongoing basis, being able to go out and get insights based off of the data that exists as part of that, that is right now upon us, and we are able to go out and engage with those from a pediatric population perspective. So several examples that I'm happy to go out and share, but in general, I think right now, the real limitation more than anything else is not the technology and the advances, but more in terms of the adoption and the equitable adoption of that sort of technology that can actually go out and benefit the larger community in general.
Yeah, so Dr. Lisa, to get into that access question, maybe talk about how you're using technology in terms of health literacy, especially in underserved communities. How are you kind of using that?
Good morning, and thanks for having us here. So I'm the founder of Grapevine Health, and the reason our company is called Grapevine Health is because that's how people often get their health information. I mean, just think about how often you or even any of you contact someone you know after leaving the doctor's office to get verification that the information is true. And how are you doing that? Most of the time you're sending a text message or you're calling someone. So we focus on what people know, how they're receiving information, how they decide they trust the information, and what they want to do with their smart devices or their mobile phones. So we create content that we push to people digitally, whether it's on social media, and we're building a platform that allows them to ask us questions, but also send them answers in the form of video. And that's really important because we focus primarily on the Medicaid population in underserved communities. And I think there's a bit of a false narrative about the digital divide, which says, well, if you're poor or if you live in an underserved community because you don't have broadband, we can't serve you. And actually, that's not true at all. Because during the pandemic, we were able to communicate with people in a variety of ways, clinically or just for information, particularly related to the vaccine, just using the internet. They're on Zoom, they're able to get on the internet, they're able to send messages with the devices they have. So a lot of our work is also to shine a light on how you can still support people digitally if they don't have the best access in the world, fanciest access, but can we provide support for them with the technology they have?
So maybe to build off the effect of COVID, how has that, some people here say, that sort of almost sped up some of the technological changes. I mean, for either of you, do you agree with that? I mean, are we seeing the telehealth changes, for example, are going to be lasting? How has COVID kind of changed it, or has it?
Yeah, so I think it's the often repeated cliche about the silver lining from the pandemic has been the adoption of telehealth, being able to go out and make care more accessible where the individual is that requires it or that necessitates the care, and so on and so forth. I think there's literature out there that talks a little bit about the digital divide on both sides of the spectrum, talking about how much of that was actually truly equitable versus not, depending on being able to go out and truly utilize something like this. However, in general, I think the ability to be able to use something like telemedicine and building upon it was actually proven out through the pandemic. There's also a greater recognition of being able to understand the population better beyond just the clinical care that is delivered, especially through telehealth and such, where you get a chance to go out and see the individual, see the patient and their family in their own setting to a certain extent, and that goes out and brings in the social element of care delivery, the behavioral behavioral side of things and everything else that go out and influence some of those decisions that are needed in order to go out and truly treat the patient and such. So, being able to go out and now start recognizing the importance of it. Some of the things that from a Children's National perspective is like being able to use geospatial modeling to be able to understand where the population is, what the demographic makeup of it is, what are some of the community-related benefits or lack thereof that are available associated with the patient population based on who you're going out and seeing, being able to consume the data associated with some of those demographics, and being able to go out and incorporate that into the care delivery processes, and then hopefully building the platform in the future for being able to go out and utilize that in a little bit more of a predictive manner to influence health and care outcomes. I think there was a study that was done from a NHS perspective that I've seen some reports of more recently about, individuals with learning disabilities were 6 times more likely to be hospitalized from the flu, and being able to go out and incorporate some of those data elements, being able to have pop-up flu clinics that go out and address those disparities to a certain extent are actual, real examples of the health outcomes that use of technology and analytics have actually been able to go out and benefit from.
Mm-hmm. And yeah, Dr. Lisa, I mean, we were talking earlier, maybe it just kind of exposed some things that already existed.
I hope we're not getting the hook.
Oh.
Okay. I think there are a lot of ways to talk about the lessons we learned with respect to technology and the pandemic. And since we have such short time today, I'll just give an example. There's a perception that seniors are not good at technology, they're not interested in using it. And I learned a lot from one interaction. This was a woman, we started with a telehealth visit. Someone from her family had to show her how to use her iPad. Mm-hmm. But when I got to talk to her on the iPad, I realized I actually needed to go to her house. Mm-hmm. So I made a home visit to see her, and she was having some lung issues. And as I was leaving, I said to her, I'm going to leave with you a pulse oximeter. And I showed her how to use it. And I said, I want you to check your oxygen, every so many hours. And then I want you to send me a text message, because she had an iPhone. Mm-hmm. So I said, can I see your phone? Because I wanted to see how she interacted with the phone. She said, well, I won't be able to send you a text message because my phone is broken. Mm. And I said, what's wrong with your phone? She said, I lost my password. I forgot my password. So in that one interaction, not only did I get to understand what it takes to get her to use or to engage in a telemedicine visit, but going to her house gave me a lot of information about the support she had, what she needed. But then that digital literacy piece associated with something as simple as, how do I use my phone? Thinking her phone is broken because she doesn't know her password. Right. So I think this is also a focus for Grapevine Health. How do we help seniors and other people who are not as proficient with the phone maximize the use of that phone or their technology for healthcare? And so the pandemic gave us many examples like that. And it was very humbling, because we take a lot for granted about who wants to do what, how people use technology, where they get information. And so it was just really a fascinating and interesting time for us to learn not just about technology, but just about humanity in healthcare.
Great. Yeah. What's for each of you, what's one thing going forward that you're most excited about in terms of healthcare technology, or the use of it, or the way it's being changed? What are you most excited about going forward?
I'll go first. So I think one of the elements that I am looking forward to seeing realized to a certain extent. We've talked about artificial intelligence for several years and such, and augmented intelligence and whatever you want to go out and kind of call it in general, right? But it's basically the ability to not have to predefine or pre-code the way that improvement can actually happen. There are machine learning and deep learning capabilities that are enabled through the use of the infrastructure that's there, the accumulation of data in general to go out and allow for that. One of those areas that we've seen being very successful outside of healthcare, within the retail space especially, is being able to go out and influence consumer behavior and being able to go out and get them to the right place that they need to. Just the success rate and the conversion rate are noted as being extremely high. Now, compared to other industries in general that are still on the adoption curve for this. On the healthcare side, similarly within that CRM side of things, or just the initial being able to go out and enable the access and engagement of technology, I think there is a great amount of utility that is perhaps a little undertapped. And we need to be able to go out and probably prove out a few use cases that I think will actually enable that. So being able to go out and understand what the consumer would need before, and being able to go out and direct them to the point of maximum impact from a clinician perspective would be extraordinary. There are lots of similar sort of use cases on the utility and the outcome side of things as well, but I know that those have probably been documented a whole lot more recently. Those are also ones I'm excited about. And doing it in the appropriate and ethical manner and so on and so forth. But just on the engage and access side of things, being able to go out and do that, I think there's a lot of untapped potential there.
Got it.
What I'm really excited about is noticing that this is the time when people are focused on health information. They are intensely trying to find information they trust, and that's our sweet spot. So this is a great time for the work we're doing at Grapevine Health. And I think because people are using their smartphones and their technology to consume health information and find health information, we need to put information out there that they want to interact with and engage with. Because if you think about it, the information you get from your insurance company or doctor's office, it's pretty dry. And actually, most of the content on YouTube is pretty dry when it comes to medical information, science, research. So I think the future of healthcare, it's not just mobile, but it's also helping people and directing people to the information they want and need, when they need it, and how they want it. So I'm really excited. And if any of you are now following Grapevine Health, we would love your feedback about how we can do better.
Yeah. Well, I think that's a good note to end on. Unfortunately, we're out of time, so thank you both.
Thank you.
I'm here.
Joining us virtually is Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation, in conversation with Steve Clemens, The Hill's contributing editor.
Hey everybody, good morning. I just want to say thank you to The Hill for some great burritos. I've been waiting for 2 years to have those. It's great to be with all of you this morning. Richard, I hope you're here. We've got a very packed house. My friend Richard Besser, if you didn't know, is the former acting director of the Centers for Disease Control, and he was a superstar at ABC News talking about all things health. And this morning, Richard, I want to start out because you said the other day that until this virus is controlled everywhere around the globe, we're going to continue to see a lot of new strains coming, and that's going to be challenging to us at all. At Robert Wood Johnson Foundation, you have been looking at health equity and the connectivity of health challenges a lot. I want to ask you, is there a price that we are paying in the United States for siloing in national terms our COVID response, our COVID dashboard, our awareness of our health fragility?
Yeah. Well, thanks, Steve. Thanks for having me, and I'm sorry I can't be there with you all in person. I think, Steve, when it comes to public health response, especially for a global event such as this, If you're only thinking in nationalistic terms, you're not going to get very far. And we're seeing that play out again and again here as the global response, the control of COVID around the world has not kept up to the control efforts in wealthy nations. And so over and over again, one thing that viruses are really good at is mutating. And if a strain develops that survives better, that has some kind of advantage, it will spread and become the dominant strain. And we've seen that over and over again. And now with the current strains, we're seeing a lot of people who are fully vaccinated, who've had not just their primary series, but their boosters, who are getting COVID again. So until this is controlled everywhere, we are all at risk. And monkeypox, as that's springing up, is again another scenario. But one of the things that's clear, I ran emergency response at CDC for 4 years. In the early parts of a response, there is a great effort by our elected officials in Congress to provide resources. But as time goes on, and especially as a crisis is ending, the will to ensure that public health has what it needs to be ready for the next event in a better fashion goes away.
Let me ask you.
You see these cycles again and again.
Sorry to interrupt, but we have such little time. I got to hammer you with all sorts of cool stuff here. But one of the things, Richard, that you've really gotten at over the years, and I'm just at a point where we so need to discuss it, but I'm so sick of discussing it at the same time, is what do we have to get out of the way to achieve real health equity in this country? You are saying, zip code matters way too much in health outcomes. What's in the way of success on that front? I know this is an obsession of RWJ, but I just want to have like a no-nonsense playbook on how we put that problem, which seems ridiculous in the United States of America, to bed.
Well, Steve, putting it to bed is a real challenge. It takes confronting the long history of our nation and how our nation has continually developed policies that privilege some and create barriers for others. This summit with a big focus on healthcare is important, but we recognize that health is about much more than having access to high quality healthcare. Clearly, it's very hard to be healthy if you don't have that. And in our nation, we're the only wealthy nation that doesn't feel that having access to healthcare is a right. But you also saw many aspects of broader concepts of equity play out during the pandemic when you looked at who was being hit the hardest. Black Americans, Latino Americans, indigenous people with death rates that far surpass those of white people. And it's not by chance. If you look at who was most likely to have a job that paid a living wage, where someone could decide to stay home if they were sick, who had sick leave, who had family medical leave. These things are not occurring randomly, and we're the only wealthy nation that doesn't see that kind of social contract with our fellow citizens as something that should be a right.
Look, I know
we're going to see that play out in the next pandemic, but we see it play out every single day.
I know it's not easy, but I know that the pandemic hit certain communities in America so much harder than others. And doesn't that give us a geographic map that we need action plans in those communities? Maybe we need substantially more investment in those communities to even out health outcomes. And I'm just, I know it's an unfair thing to give you all the power in the world to say fix it, but I'm just interested in what do we move to do beyond talking about it and actually begin addressing equity as a fundamental obsession of the American healthcare system?
Yeah. So, I think that, if you're looking at data and you're seeing a difference by race, by geography, by income, you want to then say, well, what is driving that? What are the inequities that are in place that are driving that? And what policy approaches could change that? So if you look at, survival in the United States, life expectancy, if you look at so many different health outcomes, you'll see geographic differences, you'll see differences by race. And a lot of those states that have the worst health prospects also are states that have not expanded Medicaid, are not providing health insurance to their population. They're states that haven't expanded or increased the minimum wage, so their individuals are not getting paid a living wage. Those things are things that you can tackle with policy approaches, but there has to be the will to do that. And what we've seen in America, during this pandemic, Congress came together, Republicans and Democrats, and they provided a lot of support to people, money in their pockets. They provided access to health care, all kinds of things, but it was time limited. Most recently, they provided to families an expanded child tax credit. They reduced child poverty by 30%. Unbelievable that something that simple could reduce child poverty by 30%. But it was time limited, and we've already seen more than 3 million children slip back into poverty because of that. It's not like it's mysterious, Steve, but the will to do it is just not there.
Final question, Richard. Some, both on the right and the left, Senator Bill Frist, Lena Wen, others were saying that before the pandemic, we were derelict as a country in investing in public health infrastructure. We did the minimum possible, minimum necessary, so much more needed. Are we wasting this crisis now in terms of setting up the public health infrastructure capacity we need, or do you think we're getting it right?
We are definitely not getting it right. Since 2003, the real dollar budget for the CDC has declined by 50% for their emergency preparedness work. And that just can't be if you want to be ready for the next crisis. But even now, Congress has been unwilling to give the administration the dollars they need for vaccines, for access to testing and treatment. That just can't be. If we're not going to invest in public health, we're going to see the same outcome the next time we have a major health crisis. We need to invest in technology, we need to invest in people, and we need to change the authorities of CDC. It should be optional for states to report data to CDC. You wonder why CDC didn't have real-time data? States can choose whether they send it or not, and that just shouldn't be.
Well, I want to have our audience thank Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation. Follow him on Twitter. You'll learn a lot. Richard, thank you so much. Good to sort of see you. If you hadn't been there, I'd be talking to the chair here. Thanks, Richard.
Thanks so much, Steve.
Please welcome Dr. John Martin, Chief Medical Officer of the Butterfly Network, and Kathleen Koch, author and journalist, for a sponsor perspective presented by the Butterfly Network.
IQ, that looked fascinating. I understand it is the world's first and only semiconductor-based handheld ultrasound technology you can use on the entire body, and you used it yourself to find your own cancer. Tell us about it and how it works.
It was a great experience. Not sure I was signing up to be patient number one when I joined this job, but I got a chance to see this incredible device, to walk out on stage, pull out of my pocket an entire ultrasound system. It's a phenomenal device that's transforming the way we practice medicine. If you think about the way the world has evolved, when you can put things on a silicon chip, it transforms technology.
So that just plugs right into
your smartphone. Exactly right. All other ultrasound systems require multiple probes to scan the different parts of the body. This is the only one that's on a silicon chip that can scan the entire body for a little over $2,000, and it fits in your pocket.
How is that impacting care delivery and across what settings? Because I understand that it's evolved beyond what's possible with not only traditional ultrasound, but other point-of-care imaging solutions.
I learned this firsthand through my own experience, and we've all been through a place where we have a history and a physical when we go see a physician, and no matter what the venue, it's that, and then we pause. Do I know enough at that point to make a decision on what's wrong with you and what treatment do you need, or do I need more tests? And we all know more often than not, you need more tests. And so that's either waiting for those or being sent off for those, and that's a destination. With Butterfly now, it's history, physical, image. And now I've got the right information to make better decisions, more efficient decisions, and send me on my way of getting better. And it's just transforming the way we practice medicine, no matter what the care venue, no matter what the illness or stage of disease or stage of life. Butterfly can be an effective tool to change the way healthcare is delivered.
So that's really compressed the time period. And for patients, that's so important because you hate lingering in limbo, you know, when you're waiting for test results.
What's wrong with me?
Terrible.
And when can I get better?
Right.
This changes that.
Let's talk about where it's really making a huge difference in some of the poorest rural areas of sub-Saharan Africa, and then also in war-torn countries like Yemen and Ukraine. Talk to us about the difference that it's making there.
So the importance of having a device that is not just the device, it's the user interface, your smartphone. We all know how to use smartphones. And it's the workflow. How do you transmit that information? And now it becomes so portable, it can go anywhere. So in the poorest countries of the world, 2/3 of the world has no access to medical imaging at all. Now it does. And then you couple with that artificial intelligence tools to make it easier to use, to make it easier to transmit that information, easier to interpret. Now we deal with that issue of health inequities that we spoke so much about today, so that everyone can have access to the same technology. We're in the poorest regions of sub-Saharan Africa, on the front lines of the battlefield, in Ukraine where people are injured, and imaging, that imaging information plays such an important role. About 80% of the time, when we don't know what's wrong with you, it's simple imaging that answers that question. Now we can answer it right away with Butterfly in the pocket of all of these physicians.
What about training? Is there a big learning curve before anyone can use this?
So part of what Butterfly is trying to do is accelerate that. Yes, you need to be an expert, but we're also on that journey to the home. We've started clinical studies with patients actually scanning themselves. And as you build that intelligence and expertise into the device, we'll make it easier and easier to unleash the full power of ultrasound imaging information to make decisions. So yes, there's training, there's ways in which we're addressing those, and we're being very smart and working with the FDA to making sure it's safe and effective in the journey that we're taking.
We're talking about equity, global healthcare equity here today. So is this really a game changer when it comes to that?
You know, if you think about it, when we're expecting a child here in the United States, we're wondering, is there a boy or a girl? What am I going to name the baby? In the developing world, they're wondering, are they going to be alive to see their baby grow up? This changes that. Fundamentally, we just developed an application with the Gates Foundation and University of North Carolina, where a blind sweep across the abdomen done by novices could then take that information and spit out gestational age as well as an expert can do it. And we're now deploying 1,000 probes into sub-Saharan Africa to change the lives of those people over there. This is transforming the way healthcare is being provided, whether in the most advanced institutions in the country, the most remote regions of the world, up in the space station, on the front lines of the battlefield, on the sidelines of sporting events, on the ambulance that takes you to the hospital, you name it, Butterfly is there.
Share some stories.
So I think my own is a pretty impactful story because it becomes personal. And once you, as a practicing physician, I'm a vascular surgeon, you get on the other side of the knife, you begin to appreciate the impact of time. And a little bit of a lump, I was ignoring it as most doctors do, but I imaged it, I saw this, I sent it right to my doctor, instantly said, you got a problem, let's go. And I started on my treatment, and I'm probably sitting here today because of this device. And there are many more. A physician's father came over to his house for his son's birthday, was feeling a little uncomfortable, was an emergency room physician. He took out the device, had his father lay down, saw an abnormality on the cardiac scan, zipped him to the hospital, and he ended up having a procedure to save their life. And I could go on and on and on. The importance of time, we don't think about that. Our offices and hospitals are full of waiting rooms. We're called patients. Time is such this co-pilot in healthcare that we don't really think about, but it's our enemy. The longer we wait to get the diagnosis, the longer it takes to get better.
You know, it's been our enemy so much during the pandemic. Did this come into play during the pandemic?
Huge, and I think one of the things that we learned through the pandemic is the power of imaging information for lung assessment. Actually, we've known for a long time that lung ultrasound's better than a chest x-ray.
Really?
And so as early as in Italy, when all of this first started, butterflies were deployed because so easy to clean, not a big x-ray machine that you have to clean, and you could actually scan the lungs and the heart You could also deploy them in tents, and we used it to assess patients on the severity of the COVID to decide who needed to be admitted and who didn't. We also did studies in Italy where patients were monitored at home, which is the place we all want to be. And so it was a really important, and it's accelerated now because some of the same findings in COVID we see with congestive heart failure, and in important trials we're starting now with managing congestive heart failure the same way out of the hospital, lowering the cost of care and improving everyone's life.
When it comes to maternal health, our numbers here in the United States are very poor compared to other industrialized countries. How are you seeing it begin to make a difference there?
Well, I think part of the inequities of care is the inequity of availability of powerful tools that provide imaging information that's so important to our decisions. And so hospitals have to make an institution decision on where do I spend our money. Now, all of a sudden, if a complete imaging device is available for $2,300, the access to available information becomes different. And so we're going to see that play out in rural America in a very big way. And we started that already with many of our institutions. So whether you live in the most remote regions of the United States, you'll have access to the same imaging information that if you went to a high-end academic institution to answer important questions. Not all of them, but many of them that make a decision about whether I can stay home or come to the hospital.
So how widely used is that currently?
Tens of thousands of these are scattered across the United States and across the world. We're in 31 different countries, medical schools across the country, almost every one of the top 100 hospitals. It's creeping in. And most importantly, it's now become core to medical school education. So we've got medical schools across the country that when they have their white coat ceremony, welcome to medical school, here's your butterfly. And they're learning how to make imaging and that imaging information to be a powerful part of the initial decision-making as we take care of patients.
Thank you so much. Dr. John Martin, Chief Medical Officer for the Butterfly Network.
Thank you very much.
And now, to discuss how we prepare for future global health crises and lessons learned from the COVID-19 pandemic, please welcome Dr. Anthony Fauci, the Director of the National Institute of Allergy and Infectious Diseases and Chief Medical Advisor to the President. Dr. Fauci is joined by The Hill's contributing editor, Steve Clemens.
Dr. Fauci, it's great to see you again. Yeah. I remember a few years ago when you were at the Hill's Future of Health Summit, and I said, tell me your up at night issue. What's the thing that really worries you? And I'll tell the audience, as in Business Insider, he described COVID to a T. How did you know it was coming?
Well, it's inevitable if you look at history that there have always been pandemics, even before we had the ability to adequately historically describe it. We have been through pandemics, some transforming like 1918, some that had an impact but weren't globally disruptive like 1968 and 1957. We had a mild one in 2009. So to think that we were not going to have yet again another pandemic, the only issue is how bad it was going to be. And unfortunately, one of the things you asked me, what is your worst nightmare? And I said, a worst nightmare is a combination of a virus that transmits very readily and has the capability of a high degree of morbidity and mortality. And unfortunately for the world, that's what we are living through. We're living through an historic experience, the likes of which we have not seen in well over 100 years.
Well, look, we have some real serious stuff to get into here, but I've got to address yesterday's news. And I don't know if there's a little Mark Twainism, you know, where Mark Twain said rumors of my death have been way overblown. Rumors of your retirement, are they true?
I don't know where the word retirement came in. It was kind of a little bit.
Not mine.
No, I was the reporter.
You're not going to retire, are you?
No, I'm not going to retire. I may step down from my current position at some time. And one of the reporters had asked me, and the question originated was, if Donald Trump is the next president, would you still work for him in your capacity? And I said a very innocent but true thing. I said, whether it's Donald Trump or it's Joe Biden's second term, I don't intend to be in my current position in January of 2025. What happens between now and then, I have not decided. But the one thing I do know is that I have other things that I want to do in a professional way, that I want to have the capability while I still have the energy and the passion to do them. So I don't want to go beyond January 2025. When I step down from this position, I have not decided that yet.
So for the Twitterati, that's a denial of yesterday's reporting. I just want folks to know. Okay, so Let's talk about the state of American health right now, particularly with regard to COVID. I think we're at about 67% vaccination rate and boosters and whatnot. I know from conversations with you in the past that that's not good enough. Is America its own petri dish for future variants?
America is part of the petri dish for variants because I don't think you can separate the United States from the global issue. Because as we've known painfully so, with Delta coming from India and BA.5 coming from South Africa and Omicron coming from South Africa, that we're all a connected world. So by allowing the virus to continue to propagate, be it here in the United States or in any other country, you give the virus the opportunity to mutate. And when you give it the opportunity to mutate, some of those mutations may lead to a variant. Now, a variant may not be relevant except if it has one or both of the following characteristics: that it's more transmissible than the prior variant, which is exactly what we're seeing with BA.5, as it is now pushing off the map in the United States, BA.2 and then BA.2.12.1, which is that it's sort of like a ladder of increasing transmission capability. Fortunately for us, the vaccines that we have available have been able to hold relatively strong, at least over a period of several months, to prevent you from progressing to severe disease leading to hospitalization and death. And that's not an opinion of mine, that's data. If you look at unvaccinated versus vaccinated with a 1 boost versus vaccinated with a 2nd boost, the differences between hospitalization and death among vaccinated versus unvaccinated is without a doubt stunning and obvious. You don't need a statistician to tell you. You just look at the curves and they're there. So getting to your point, having 67% of the population in a rich, developed country like the United States is unacceptable. We have got to do better than that. And of those 67%, only about half of them have received a first dose of a first boost, which again is unacceptable. When you have the
So that takes us down to effective, effective vaccination at 35%.
Right. Yeah, the confusion, Steve, and it's an understandable confusion, is that when you have a very transmissible virus, the ability to prevent infection and transmission is much less robust than the ability of that vaccine to prevent severe disease. So what we're seeing is increasing cases. There's about 130,000, 40,000 a day. That's an egregious undercount because all of us know people who get infected, have mild symptoms, get a positive antigen test and never report it to anybody. So it is very likely that the actual number is much more than 130 and 40,000. Number two, there's no doubt that the hospitalizations are going up, and that's purely quantitative, even if the virus is not inherently more pathogenic than the prior variant. When you get more people infected, if the proportion of infected people still stays the same, your hospitalizations are going to go up. And that's what we're seeing. And that's the real unfortunate, and I say tragic part of that, is that we have the wherewithal to stop that, at least to contain the serious nature. What we do need, looking forward, are better vaccines that have a greater durability so that you don't have to say X number of months later, your immunity wanes. Even if the strain doesn't change, your immunity wanes. And secondly, we desperately need a vaccine to prevent acquisition and transmission. And one of the ways to do that...
We need a new vaccine.
Oh, absolutely. We need the next generation of vaccines, particularly mucosally administered vaccines, that would do much better.
Who's likely to have it?
What do you mean, who's likely to?
Who's likely to produce that vaccine?
We are, if we have the resources. We have an incredible amount of talent in this country. If you look at just what we did with the mRNA, the immunogen design, the stuff that came out of the NIH,
So are you
the stuff that
saying
came
you're
out of the
not
industry.
getting the resources you need for that next vaccine?
No, I mean, look what happened. We asked for a certain amount. Originally, we wanted 22 plus billion. It got cut down to 15. And then the international part got cut out with the 5, and we're left with an amount that, first of all, we want to make it clear that we are very, very grateful to the Congress for being as generous as they have been.
But you'd like to be more grateful.
Well, not like, it's essential that we get more resources, or we are not going to meet the challenge that's inevitable. What I don't want, Steve, speaking about retirement, which I'm not going to do, I don't want to have an interview with you 3 years from now when we have yet again another challenge and we say, do you remember back in July of 2020?
I know we're going to have an interview 3 years from now on something else, and it raises this question about both the science and the political ecosystem in your experience. You've done Zika, Ebola, N1H1, HIV, AIDS, and of course, COVID-19 and its various forms. I guess, are we learning from episode to episode to episode, or are we getting worse?
From a scientific standpoint, we're learning. Clearly, if you look at what's happened with the vaccines, that never in our wildest dreams 5 years ago would you have thought from the time a virus was identified to the time you had hundreds of millions of doses going into the arms of individuals, it would be 11 months. Historically, when people start writing the history of this, there'll be the scientific history and there'll be the public health history. And unfortunately, the public health history has been severely marred by the political divisiveness in this country, where you have the decisions upon parts of the country to whether or not to use a highly effective vaccine, to whether not use drugs that clearly don't work, are actually decided on ideological lines. I mean, forget, you know, Steve, I am not a political person. I have no political affiliations. But if ever there was no place for ideological determination of public health principles, it's when you're in the middle of a deadly pandemic. So that's the reason why you hear me all the time, and very people say it on the far right criticize me for that. We're not trying to take your liberty away. We're trying to tell you to do what's prudent to save your life.
So what would help you? You heard me ask Richard Besser a moment ago what we basically needed to do by way of investment in public health infrastructure, and were we derelict? And he basically said yes, even in this moment. And I'm just interested, you know, with you as the quarterback of a team of scientists focusing on this deadly pandemic. It's had terrible, terrible impacts on the world and the United States. What do you need to succeed that is not in place now?
Well, Richard said it from a public health standpoint. As you know, even though I am, and I am very proud and privileged to be the chief medical advisor to the president, that there are two pillars of the approach. There's the scientific approach, which my entire professional career, up to 40 years as the director of NIAID, that I've been responsible for, is preparing us scientifically. Then there's the public health preparedness. And as Richard said, very appropriately, we have let that get a level of attrition which is dangerous, where you really are not in the 21st century of being able to do the kind of communication, surveillance, the kinds of things that you need. So what we've got to do is keep up and continue to support the scientific basis which allowed us to have a transforming vaccine. At the same time, you dramatically increase and support our capability for global public health interaction, transparency, communication, all the kinds of things that you need to do. And we are lacking in that. We have let that attrit for a very considerable period of time.
You know, I know that you were not going to tell me what your private conversations with President Biden are, but I'm interested in the outlines of whether you generally go to him and say, Mr. President, we need you out there asking Congress for that money. That if we do not get that money, we're not going to develop the next generation of vaccines, and this country is going to be hurting badly.
Well, I think if you just look at what's happened, it answers your question, Steve. Yes, I and many of my colleagues on the team have encouraged the president to do that, and the president has come through and actually done that. I mean, just listen to what the president says. He keeps saying over and over again, we do need the Congress to come through with support if we're going to do what we want to do. So we don't have to convince this president to do that. He's already doing it.
Let me ask you finally, there's an organization I came to know through you. Richard Hatchett heads the, I guess, the Coalition for Epidemic Preparedness Innovations.
Right, CEPI.
And CEPI is designed to be a kind of global platform, funding some things, helping to kind of raise awareness, building an international fast response mechanism to not only this pandemic, but future ones. Does CEPI have what it needs? I'm fascinated by the fact that our health is a function of another person's health that may be very remote from this country.
Right.
And how we make better investments in that infra. We're fighting over resources in the United States. What resources do we need to be fighting over globally? We have Atul Gawande coming up and ask him the same question. So maybe you can give me some foreshadowing to what he's going to say.
Well, Atul's organization, USAID, is suffering like we are from pulling away that $5 billion for the international, which he needs and USAID needs. I don't want to speak for Atul. You'll hear from him shortly. But with regard to CEPI, we have formed very recently, it was just announced a week or so ago, a coalition with CEPI to do just that, pandemic preparedness, with a partnership between ourselves and CEPI, which is great because partnerships help because they leverage each other.
Well, I'm going to have to leave it there. Can I just say it's such a privilege for us to talk with someone who has, without embellishing at all, saved millions and millions of lives. Thank you so much, Dr. Anthony Fauci. Not about to retire, just want to put that on the record. But Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Disease. Thank you so much. Let's do an MBS. Coach Trumpo. Take care, my friend. Thank you. I stay seated. Guess what? I get to stay here.
Please welcome to the stage Dr. Gawande, Assistant Administrator for Global Health at USAID.
Atul, thank you so much for joining us. Is my mic's on? Okay. We've known each other in lots of different ways, and I consider you're one of the most brilliant writers in the world. You're one of the most brilliant data scientists. I don't know how the government persuaded you to come in. So what was the big offer they made to you?
There's a crisis.
It's a crisis. Is the mic on? There's a crisis. It's an opportunity as well. And for me, my entire career, my writing, my public health work, my career as a surgeon has been about how do we make sure we have health equity, by which I mean we have enabled an 80-plus year life expectancy if you can get access to the public health services and the core healthcare delivery capabilities that we've created in the last century. Only a part of our population, even in the US, gets to have that life expectancy. Enabling that capability to go to every person in the world, town by town, to every person alive, is the job of our generation. And this crisis has made incredibly clear, the COVID crisis, that it's not enough to have the breakthrough innovations, we have to have the follow-through innovation. And this is a team at USAID. I get to lead 2,500 people, $7 billion in deploying capability around the world.
So I'm going to tell the audience, I'm going to overstate something for effect. I'm not sure I believe what I'm about to say, but I want to use it as a way to raise a point. I used to be a trade policy wonk many years ago, and doing trade policy used to sort of ask, okay, if we really wanted to achieve outcomes in labor and environmental issues, you would negotiate differently than we were. And so my question to you, and it's a serious one, if we really wanted to change global health outcomes, and we wanted to take seriously the fact that my health is connected to a person in Sri Lanka's health, what would we be negotiating for that we're not doing today?
Well, first of all, you got to understand, global health is one of the few examples where human beings have come together and made steady year-by-year progress. The exception has been the last 2 years. This is the first reduction in global life expectancy.
We've gone backwards.
We've gone backwards. First reduction in global life expectancy in more than a century. And only a part of it has been directly because of COVID. COVID hit the lowest income parts of the world, the poorest 2 billion, because their health systems then also were harmed along the way, because the economies fell through and they didn't have the buffers we'd had, because food prices skyrocketed. All of those things meant that the majority of the deaths
have been in children under 5, women in childbirth, and the broader health system and the issues there. So as we take on, I mean, we have 2 core issues then where we have to act differently. Number one, we've gotten through 3 of the 4 quarters in this football game, and we can't give up the game now on COVID, right? That at the center of it, we still have surges that will come. In places like the United States, we now have the tools, thanks to teams like Dr. Fauci's, who have given us vaccines, but also rapid diagnostic tests, antiviral pills that are 90% effective, even if you aren't vaccinated, and addressing high-risk people to disconnect the cases from the deaths so far. Those rapid diagnostic tests for people in most of sub-Saharan Africa, for example, and Haiti and other parts of the world, those let alone the vaccines, the antiviral pills, they're not there. So the first thing we're missing is we got to complete this job and make that capability available everywhere.
So Dr. Fauci just said you don't have the resources you need.
That's correct, and we've been going to Congress since the end of December, flagging that our money for being able to field a COVID task force that would enable delivery of that capability I just described, that funding ran out now.
What have you asked them
ago.
for, and what did they give you?
Well, so we asked for a minimum of $5 billion just to keep the basic operations running. What came through is 0. So we're within.
That's a tweetable moment, if any of you are interested. And it's easy. People understand it.
We are grinding our operations to a halt. The COVID task force will have to go away in the next couple of months. Now, I hope springs eternal. We continue to ask for the funding to be there for COVID in order to enable delivery of the vaccines that protect people from deaths, enable bringing rapid diagnostic tests and antiviral pills through the world.
So whenever I sit down with Dr. Fauci, it's always extraordinary because you're basically sitting with someone who is the living encyclopedia of infectious disease in the world over the last 50 years, right? So it's extraordinary what he's done.
What he did in HIV alone before
HIV
COVID
is an extraordinary story.
Remarkable.
So I guess I always worry about what will we be talking about 3 years from now, 5 years from now, and monkeypox is a new issue, and you're concerned about it. Tell us, as you look into the crystal ball where people are laughing about this, joking about it, not taking it seriously, what are we getting wrong as we look not only at that, but other potential pathogens that could come down the pike?
Yeah, so number one is to understand the world has changed in significant ways. Climate change is a big part of it. It is driving much more shifts, big shifts in where human beings live and where animals live, and it's creating new contact points between animals and humans where animal to human transmission of virus is turning up. Monkeypox is an example of that. Now, it is a painful rash, not at the deadly level that we would talk about with COVID, but how it mutates if it continues to spread around the world, and taking it seriously as something to stop is a critical part of the public health armamentarium. Even more importantly, we will have continued surges of outbreaks. Just in the last 3 months at USAID, we have dealt with an Ebola outbreak in the Democratic Republic of Congo. We have had a Lassa fever outbreak in Guinea, and just in the last week, Marburg virus, which is a 90% deadly virus, with 2 cases in Ghana. Stopping and controlling that capability is what we call global health security. It is pandemic preparedness. And investment to fight the fires now but prevent the fires later is a critical part of what we do. There actually has been bipartisan support for making some initial investments in those areas. Seeing that those continue are going to be absolutely essential. I'm going to tell you a good news story here. Ebola in 2014 to 2015, it was 4 months of circulating virus in West Africa before it was identified by physicians, diagnosed and notified with a rapid response created, now a slow response, right? 10,000 people died. In 2020, our investments, the USAID, CDC, and others, enabled the Democratic Republic of Congo to have an Ebola outbreak and recognize it within 15 days, mount a response, and therefore contained it to 55 deaths. In April, the last Ebola outbreak happened. And in fact, the number of outbreaks are escalating because of those contacts between humans and animals. And that outbreak had notification within 48 hours. They had the diagnostic kit at the hospital where the person presented with hemorrhagic fever. They tested them right away. They called out the outbreak. So within 48 hours, a response happened, contact tracing, vaccination, isolation. It's 5 deaths and it's declared over as a local outbreak that could have been another global one. These are happening, part of my job is these are happening on a weekly basis, these kinds of outbreaks, and making sure we have the systems in place to stop them is going to be our critical to our future.
Let me ask you, I don't know if you remember, but the last time we were hanging out, we were hearing this fascinating presentation about data overlays and looking at zip codes, not just zip codes, but deep down in communities that was looking at social determinants of health, race, income, diversity, et cetera. And I always wondered if we could globally map that and not just look at the negatives, that what could we learn of looking at data and looking at, when it comes to community health outcomes, what are the ones that are getting it right doing? Are they just rich? Or are they, what are the factors that drive positive health? What are the factors that mattered in taking one of those bleak places in the world and turning it into a positive one? And so I know it's a New Yorker style question, but if you were to write that article about what lessons we need to heed and take seriously, knowing it's a triple lever dashboard, I mean, I sort of look at this as sometimes we need to know the bank shot, so we have to get right that may not always be about a vaccine, but there may be other determinants that matter.
Yeah, this is critical. So, the zip code, the postal code analysis has shown that the same places that people are in the United States dying of opioids are also the risk places for dying of COVID, are also the risk place for dying of heart disease. And there are a couple critical components that have turned up so far. Number one is the ability of the local government to mount a response to support people's needs. And second is the strength of primary health care. And that is a global story. The resilient workforce who are capable of addressing what the top needs are of a given community is your primary healthcare workforce. They are the ones who do the prevention, do the counseling, but then when vaccination needs to happen, they turn around with the vaccinations. I was in rural Ghana just a few weeks ago, and it's the same story I saw there that I saw in my hometown of rural Ohio growing up, which is that my mother was the second pediatrician for the entire community where we lived. And the story in Ghana is the same thing, that they had a malaria outbreak, they had COVID vaccinations to deliver, they had that rise in maternal and child deaths and needing to address acute malnutrition and so on. And it's the same people who do the work. It's the doctors, the nurses, the midwives, and the assistants who are either there or they're not there in those frontline clinics. They're either trained or they're not trained. They're either paid or they're not paid. And if they are salaried, if they are paid, they actually, you can be salaried and then your paycheck doesn't come. If they're trained, if they're actually supported with management and that connects people into a proper primary healthcare clinic, the reduction in mortality that Ghana achieved within 3 years was 50% for children. Within 7 years, a 70% reduction in mortality by working across that capability. We don't have that in the United States. We have more than a quarter of people who don't have a primary health care physician. Another quarter who do, but aren't connected to them. And those are the people who get lost to the system, and that's the story the whole world wide over.
Let me finish with an easy question for you, Atul. Roe v. Wade. Roe v. Wade, in my view, I'm trying to process what the impact of it is, and I think one of the ways in which I look at some of the challenges we have in U.S. healthcare, but I think it's a global problem, is whether people feel like they have agency in that, whether they feel like they can prevail, drive their own decisions, become literate, challenge the healthcare community to perform better, or whether they're victims of the process. And I'm interested both in terms of your USAID work, Does that decision from the Supreme Court make a difference in the footprint of what you do in the world? And what do you as a person think this will do to the social contract between the individual and our healthcare system?
So the Supreme Court decision that repealed the right to abortion is important on multiple dimensions on that global scale. So first thing to emphasize is that the Biden administration remains absolutely committed to the sexual rights and sexual health of people and the reproductive rights and reproductive health of women. At USAID, funding to support abortion has been restricted for decades. So we actually have some experience with what happens when that funding might not be there.
Right.
And what I would tell you is that the calls coming in and the meetings that I've had in the last few weeks has been concern about a couple of things. One is confusion, and we have a lot of experience with making really clear that if women come in who've had unsafe abortion, it's our job to be able to provide appropriate post-abortion care.
Right.
Second of all, women having miscarriages or coming with bleeding, coming in with life-threatening issues. We need to be able to make sure that the health providers on the ground know that they have to care for those women, that it's a matter of life and death, and this is absolutely critical. We make 100% committed to making sure that the right care is happening. Second is the fear that this is the beginning of taking away sexual privacy, taking away contraceptive rights. There's been decades of bipartisan support in the US that made us the leading donor and supporter of distributing family planning capability around the world, and that is not going to stop.
Well, let me just finally say that I hope that you're keeping notes in a journal, as I would love to read your insights about how we can all do this better. And one of the most incredible writers on health in this country, Atul Gawande, Assistant Administrator for Global Health at USAID. Thank you so much, Atul.
Thank you, Steve.
Really appreciate it. Thank you.
Welcome Atul Saran, Executive Vice President and Chief Strategy and Development Officer at Emergent BioSolutions, for a sponsor perspective presented by Emergent BioSolutions.
Good morning, and thank you all for coming here tonight. It's an honor to join this group of leaders to have an opportunity to talk about the innovative and equitable future of healthcare. And in particular, I'd like to focus a little bit on how we better prepare America for future public health threats. As we work our way through the ups and downs of this pandemic, and we look at current events like Dr. Gawande was mentioning about the monkeypox outbreak and the Marburg outbreak that we've heard of and seen so recently, it could be easy to focus our efforts on what was most recent. But unfortunately, preparedness doesn't work that way because public health threats don't actually work that way. Now is the time for action to make sure that America is prepared for the next public health threat. If we forget the lessons of the anthrax attack that happened just down the street over 20 years ago, or the other types of threats that we've faced since then, we might be prepared against one set of issues, but fail to address the more dangerous threats or the exposure from other concerns, and leaves ourselves dangerously exposed. From deadly pathogens like anthrax and smallpox and Ebola, to the opioid crisis, the U.S. government, particularly the Assistant Secretary for Preparedness and Response and BARDA, since their inception, and other agencies like the Department of Defense and the National Institutes for Health, have been there to really help drive the response. Since our inception over 20 years ago, Emergent has been focused as its mission on really driving forward solutions to public health threats with these U.S. government agencies and others across the world to prepare for an ever-increasing set of risks that are both known and unknown. When it comes to the last 3 years, we've seen the real benefits as a society of public-private partnerships as well as scientific collaboration. We've learned what works and, critically, what doesn't work and where we can do better. Making these types of relationships work really takes a lot of communication, trust, clarity, and above all, certainty. We need to continue to amplify and expand upon those things that have actually worked and take a look at those things that we learned in the pandemic didn't work and rethink them. Above all, we've learned how important it is to be prepared for almost anything, even the unimaginable. Real-world events remind us that public health threats can emerge at any time, and so the question that we need to ask ourselves are, how can we better protect and enhance life to create a better and safer future for all? Through these many years of collaboration with the US government, we've learned a great deal, including what's worked and what hasn't, and how we put America on a stronger footing for the next public health threat, whether it's accidental, intentional, or naturally occurring. Even in the most polarizing times, preparedness has not historically been a partisan issue. And so it's not surprising that we've started to see the emergence of real, true bipartisan leadership as we come out of the pandemic. For example, the Biden administration has proposed a $65 billion initiative to enhance America's preparedness efforts with an increase in the medical countermeasures that are in the Strategic National Stockpile. Second, as you'll hear from Dr. Disbrow, I'm sure, in a few minutes, BARDA has laid out a strategic plan that really sets America up for preparedness for the next pandemic. And third, Senators Patty Murray and Richard Burr have put forward the PREVENT Act in a bipartisan way, which really helps drive future infrastructure of the United States, making sure that we're prepared for the next set of attacks. We know from experience that the best preparedness plans come from debate around what's worked and what hasn't. And regardless of the details of what's agreed upon or not, what's really critical is that we need to have a unified biodefense budget to face the challenges that come next. Critically, this has to be sustainable. This cannot be a one-and-done effort. This is something that is continuous and ongoing. Prioritizing preparedness requires 4 important things. The first, and this builds upon what Dr. Gawande was saying, there has to be a trained and skilled workforce. We oftentimes think of first-line healthcare workers as those people who are in the hospitals, but manufacturing systems and R&D systems are absolutely critical in the middle of the pandemic, and making sure that there's a trained and skilled workforce that's ready and prepared to go in terms of responsiveness is absolutely critical. The second is expanded investments in research and development. As we saw with new technologies being brought forward, we have to make sure that we've got new, different solutions for each unique type of threat that is actually going to come up. Third, we need to be building and regularly exercising our manufacturing capability and capacity. This isn't something that you can easily ramp up in the middle of the pandemic. It has to be used for regular production of real-world products and the potential to adjust when the need arises. And then the fourth thing is really making sure that there is an appropriate supply chain for the medical countermeasures that are in the Strategic National Stockpile, including all the materials that are necessary to actually produce those products. A sustained commitment must also be coupled with careful, responsible communication based on science that instills confidence in America's response. And this is everyone's responsibility, everybody that's involved in the responsiveness. Successfully combating the next public health threat requires reliance that Americans are trusting the tools and the communications that are coming from the government in order to respond effectively. There were many near miraculous things that happened during the course of this pandemic. Chief among them was the development of novel vaccines and therapeutics that were effectively developed, tested, and made available so quickly to the public. But history, along with current events such as the monkeypox and Marburg outbreaks, as well as the Russian threat or the Russian war in the Ukraine, reminds us that we rarely have the luxury of responding to a single threat at a time. We know that individual threats can continue to evolve, and we may be dealing with multiple threats at the same time. As the adage goes, you can't fight tomorrow's war with yesterday's army. It's clear that America is better positioned to meet the threats now because of the steps that we've taken together, but we still have a ways to go before we're completely prepared for the range of public health threats that are on the horizon. I look forward to hearing more from the other panelists that come up today, and thank everyone here for coming to discuss ideas and really figure out how we create a safer, healthier world where peace of mind prevails. Thank you very much.
Please welcome Dr. Gary Disbrow, the Director of the Biomedical Advanced Research and Development Authority, and Bob Cusack, Editor-in-Chief of The Hill.
So Gary, thanks for joining us. Talking a little bit backstage about the alphabet soup of acronyms and agencies. Tell us a little bit about BARDA. Some of our viewers may not know what BARDA is, and kind of a day in the life, which must be pretty hectic nowadays.
It is. So Bob, first, thanks for the invitation. I really appreciate being here. Many probably still don't know what the Biomedical Advanced Research and Development Authority is and what we do as part of the federal government response and preparedness for public health. So we were established by legislation under the Pandemic and All Hazards Preparedness Act in 2006. Our mission is to develop medical countermeasures, vaccines, therapeutics, diagnostics, and devices to address chemical, biological, radiological, and nuclear threat, pandemic influenza, and emerging infectious diseases. And we've been very successful. We are the advanced research and development arm for the federal government. So you heard Tony Fauci speak earlier. We are a transition partner for programs that start at the NIH, the earlier research and development, and then we transition those to advanced research and development, typically after phase 1. And to date, we have supported 63 FDA approvals, licensures, or clearances of products that cut across our threat space.
And as far as your job in dealing with other government agencies, how does that work? If you can kind of take us behind the scenes, are there Zoom calls where, because there must be so much more coordination. I'm not saying there wasn't coordination before, but much more now.
So there is. So there's also an overarching body, the Public Health Emergency Medical Countermeasure Enterprise, or the FEMC, which coordinates across the federal government, not only Department of Health and Human Services, but other departments, and brings together the leadership of those different departments and agencies, and it's led by the Assistant Secretary for Preparedness and Response, Ms. Dawn O'Connell, where we discuss the strategies, for development of medical countermeasures, response strategies, as well as just any public health concerns.
A lot of issues right now, obviously, that you are in the middle of. Can you just give us a preview of kind of what you're dealing with on a daily basis, the health security landscape as it is now? We've got COVID still, going strong, even though we're all tired of it, but still, monkeypox, kind of where we are right now and where we're going.
Yeah, so, we have a group that's approximately 450 individuals, very dedicated to public health. I could not be prouder to represent them and just how driven they are. So we recently just ended the outbreak of Ebola in the DRC. There's now a confirmed case of Marburg in Ghana and a second probable case. We've been dealing with COVID for the past 2+ years, and now for monkeypox. And for monkeypox, our development of smallpox and our preparedness efforts for smallpox led to the licensure of the Jynneos vaccine, and that was actually the first contract I ever awarded as a federal employee, was the contract to Bavarian Nordic to develop that vaccine. And it is now available to help prevent monkeypox, as well as we supported the development of the 2 antivirals, TPOXX and Tembexa, that are currently being used to treat individuals who are symptomatic. So right now it is monkeypox, COVID, and Marburg, and we continue to work tirelessly to make sure that we're prepared for any potential threat that may come. And the one that scares me the most is the unknown threat. I mean, you heard Tony speak before about a pandemic, a respiratory virus, and that is definitely one of our major concerns. Pandemic influenza is one of the efforts that we support, but it's also the unknown.
What have you learned, lessons learned from COVID?
So first is that the government can really do incredible things when we all work together. So the OWS, the Operation Warp Speed program that was established under the previous administration and has been expanded under this administration, really brought together the best of the federal government. And the reason that it worked is that it was a single person who was making decisions, and that was General Perna. A 4-star general who has since left the federal government, but very thankful for his service. But it brought together the entire federal government on just a unified effort to develop vaccines, therapeutics, and diagnostics as quickly as possible.
And the structure of it too, having one person at the top.
Correct.
That was key.
Correct, because there was no, siloing of the different agencies within departments. And we always work together, but this really brought everybody together and really expedited the development of the vaccines and therapeutics.
We talked about monkeypox in DC. It's now the highest rate per capita across the country. Where are we going with this? Because it seems like it's getting worse.
So hopefully, through public health measures, we will be able to decrease the spread of the disease, and with available vaccines and antivirals to bring it under control. I do think we are going to see the numbers increase for the next several weeks, but we're working very hard and working with the manufacturer of the vaccine to make more vaccine available so that we can address what many people hear is a shortage of the vaccine. There are certain jurisdictions where the demand is outstripping the supply that we have available, but we continue to work with the vaccine manufacturer to make as many doses available as possible.
BARDA has a strategic plan like other government agencies. Where are we going between now and 2026?
So I thought it was, when I became the director of BARDA, our previous strategic plan was issued in 2011. So it was 2011 to 2016. It was one of my primary goals to put together a new BARDA strategic plan. We have learned so much, we've grown so much as an organization. And so the future, the topic for this symposium is innovation, and innovation really is the future for BARDA. We have been very successful at developing medical countermeasures, which most people would consider, the standard medical countermeasures, vaccines and therapeutics and diagnostics. But as we move forward, innovation is going to be the key. Innovation is one of our objectives under Goal 1, which is preparedness, to make sure that we have a robust pipeline and portfolio of products that we can move forward. And under innovation, we are supporting different efforts. So in 2016, we established the Combating Antimicrobial Resistant Accelerator, or CARB-X, that was in partnership with our colleagues at NIH to reinvigorate the development of antibiotics. AMR is a huge public health concern, and AMR will also complicate any large event that occurs in the United States or globally. In addition to that, in 2018, we stood up an entire division within BARDA called the Division of Research, Innovation, and Ventures, and they are investing in innovative technologies. We also changed the way that the government partners with companies, and we became more innovative. So we have what is called an easy BAA, and it really is easy for companies to partner with the federal government. It's a 2,000-word abstract. We review it. If we're interested, we have further discussions with the company and can award contracts in as little as 30 days. In addition, we also set up our Blue Knight program, which is our partnership with Johnson & Johnson Innovation, their J-Labs program. And the Blue Knight DC is located right here at Children's National Hospital in Washington, DC. We've made 23 awards, and these are innovative small companies that we're supporting. They have access to the J-Labs infrastructure, as well as mentorship from BARDA. And then finally, in 2021, we started BARDA Ventures. So BARDA Ventures was an authority that we were provided under the 21st Century Cures Act, where BARDA can partner with a venture capital firm that uses venture capital practices to make investments on behalf of the government. And so Global Health Investment Corporation is our partner under the BARDA Ventures. We provide funding and strategic direction to them, but they go out independently and make investments on behalf of the federal government and can take equity positions in those companies.
You mentioned investments in the federal government, and pre-COVID, I think there was maybe healthy skepticism of investing millions or perhaps even billions now, so we avoid spending trillions. We've seen that with COVID, literally trillions of dollars. Do you think that mentality has changed in the wake of COVID?
I hope, but we appreciate every dollar that we get from Congress, whether it's through annual appropriations or through supplementals. I've always said that preparedness is less expensive and easier than response. If you're in response, you're always chasing the pathogen, versus in preparedness, we're trying to make sure that we have vaccines and diagnostics available, similar to what we did for monkeypox. But we get about $2 billion a year to make those investments across 18 different material threat determinations that are issued by the Department of Homeland Security for different pathogens or agents that we need to address. For COVID, in a partnership with our colleagues at the Department of Defense, we've invested over $68 billion in just over 2 years. And so, and that doesn't even, account for the trillions of dollars in economic, setbacks, as well as the socioeconomic impacts of COVID-19. So to me, preparedness is less expensive than response.
Last question, this is a big one. What keeps you up at night?
Everything. Sometimes I'm so tired I just fall asleep. But
sometimes it might be hard to fall asleep because you're getting those briefings on what's out there, right?
It's really what keeps me up at night is making sure that I support the team that we have, because they are, again, the most incredibly dedicated group of individuals I know of in the federal government, and there are many great federal employees. But to make sure that we are prepared so that if something does happen, we have the vaccines and therapeutics and diagnostics so that we can appropriately respond.
Absolutely. Well, thanks to you and your staff, and thanks to Gary Disbrow for joining us today and educating us on BARDA. Thanks so much.
Thank you.
Appreciate it.